Good morning, everyone, and thank you all for taking the time to join the Coalition for Health Funding and Ad Hoc Group for Medical Research for our third event in our Medical Research and COVID-19 series. I'm Erin Morton, Interim Executive Director of the Coalition for Health Funding. Before we begin, I want to go over just a couple of housekeeping items. First, there'll be time for questions at the end, but because we're using Zoom's webinar format, all audience members are muted. To ask a question, please type your question into the Q&A function. When submitting your question, be sure to include your name and the full name of your organization or congressional office. I'd like to note that this briefing is not open to members of the press. So if you have joined us inadvertently, we appreciate your interest, but would kindly ask that you disconnect at this time. NIH-supported medical research across the country is a key tool to battling COVID-19 and its wide-ranging impact. Our organizations partnered on this series in an effort to facilitate opportunities for advocates and congressional staff to hear from the directors of NIH's Institutes and Centers about how research and ongoing work can inform our response to the virus, as well as the impact the pandemic is having on existing research across the agency's broad portfolio. We have two moderators for today's briefing. Erica Sward, a member of the Coalition for Health Funding Board of Directors and Assistant Vice President of National Advocacy at the American Lung Association, will facilitate the Q&A portion of our discussion. And to introduce our speaker for today's briefing, I'll turn things over to Mary Lee Watts, Steering Committee member of the Ad Hoc Group for Medical Research and Director of Federal Affairs at the American Society for Microbiology, also a CHF member. Mary Lee, over to you.
Thank you, Erin. And welcome, Dr. Gibbons. CHF and Ad Hoc Group are pleased to welcome Dr. Gary Gibbons, Director of the National Heart, Lung, and Blood Institute. NHLBI is the third largest institute at the National Institutes of Health, with an annual budget of approximately $3.5 billion and a staff of more than 2,000 people, including federal employees, contractors, and volunteers. NHLBI provides global leadership for research, training, and education programs to promote the prevention and treatment of heart, lung, and blood diseases and enhance the health of all individuals so that they can live longer and more fulfilling lives. Since being named director, Dr. Gibbons has enhanced the NHLBI investment in fundamental discovery science, steadily increasing the pay line and number of awards for established and early stage investigators. His commitment to nurturing the next generation of scientists is manifest in expanding funding for career development and loan repayment awards, as well as initiatives to facilitate the transition to independent research awards. Dr. Gibbons provides leadership to advance several NIH initiatives and has made many scientific contributions in the fields of vascular biology, genomic medicine, and the pathogenesis of vascular diseases. His research focuses on investigating the relationships between clinical phenotypes, behavior, molecular interactions, and social determinants on gene expression and their contribution to cardiovascular disease. Dr. Gibbons has received several patents for innovations derived from his research in the fields of vascular biology and the pathogenesis of vascular diseases. With that, I will turn it over to you, Dr. Gibbons, to give an overview of NHLBI's current activities. And when you're finished with your presentation, Erica will open it up to our audience for questions.
Well, thank you for that very generous introduction. I presume this is a relatively informal Zoom in which we may have an opportunity to dialogue and address questions and answers, but let me just sort of kick things off by what everyone recognizes, that we're in the midst of an unprecedented public health crisis created by this novel coronavirus, SARS-CoV-2, and that's really devastated communities all around our country with millions of cases, over 220,000 deaths. And its devastating impact has been felt by nearly every community in this country. And unfortunately, it's also particularly exacerbated existing health inequities. And we know that some of the hardest hit communities are those that are communities of color, with African Americans, Latino, American Indian communities, with several-fold higher rates of cases, hospitalizations, and deaths. And This group also recognizes that this coronavirus is spread by respiratory droplets and gets entry through the lungs, and therefore its primary injury is to the lungs. But we also have learned that it also attacks the heart and affects the blood systems, and probably in its sequelae affects sleep systems. And so the NHLBI very early on recognized that this pandemic was going to affect our portfolio of heart, lung, blood, and sleep science. And that if the country was going to get through this pandemic, it was going to be through science and scientific discovery and its application to understanding how this virus attacks the body and how we can fight the virus, particularly in our case, how the virus affects the host organs like the lung, the heart, the blood systems, and what interventions could be brought to bear that could reduce the incredible case fatality rate of this virus well beyond any typical kind of viral pneumonia that we've encountered previously. And so we've attempted to be as nimble and adaptive and rapid as part of the NIH response as we could. When it became clear that the original cases weren't just those who came in from other countries and travelers, but was starting to spread throughout the community. So back in March, we knew that we had to marshal our entire community, and we appreciate many of those of you who are on this phone line that we called out for proposals and supplements and notices of interest for mobilizing the research community to address this pandemic. And we got an incredible response to that, that leveraged our existing assets as the way to really be most nimble, most adaptive, and rapid in our response. In fact, we mobilized experts right away. We had about 3 workshops and roundtables in a period of weeks in March as it became clear that what we were dealing with. And as a result of that, and the call for supplement ideas, quite frankly, by early April, I believe, yeah, it's April 9th, I believe, that we were able to have received a proposal through the PEDAL network at that time that addressed one of the questions that was burning at the moment, and that was whether hydroxychloroquine had any efficacy at fighting this virus. Because at that point, there was nothing that was known that would be really effective and safe. And that needed to be tested. It was really unclear, in fact, controversial, as to whether hydroxychloroquine was good or bad. And that's why we do randomized controlled trials. And so by early April, that trial had already launched. So within almost a month of recognizing the depth and breadth of this pandemic, recognizing what was happening on the ground, how it was affecting heart, lung, blood systems, we were able to get a proposal reviewed, cleared through IRB, DSMB set up, protocol set up, and executed and launched. And all that by April. And that really was the pattern up until literally this week, where in a serial fashion, we've been engaging the community to respond and work to put together platforms that would enable us to have a coherent, systematic research agenda that addresses the pandemic, designed to understand how this coronavirus is affecting the body, which literally we learn something new every month about this virus, as well as develop strategies and finding out what works and what doesn't work. And in the meantime, adapting our platforms to respond more and more effectively. And so early on in May, we started to develop a whole new platform. We had a series of networks in heart, lung, and blood. And for the first time in the Institute's history, we sort of said this is an all hands on deck moment. And we started to knit together a network of networks and launched a coordinated activity in that regard that we now call Connects. It brings together networks like PEDAL in the lung, the cardiothoracic surgical network, tactic in the blood division, all to working together on what are called master protocols, adaptive protocols that enabled investigators across these platforms to test and see what's working, what's not working. And that was launched again late spring. Similarly, we joined with trans-NIH efforts, the accelerating COVID therapeutic interventions and vaccine. The active platform that's trans-NIH was also something that the NHLBI joined into. And indeed, a key part of that was driving the recognition that this virus, when it attacks the blood vessels and the lining of the blood vessel, the endothelium, it engenders a hypercoagulable states, a propensity to develop blood clots, literally blood clots all over the body. That's one of the phenomena that came out in, again, that March-April period, while the clinicians were getting to know what this virus did. We're seeing thromboses of the veins, the arteries, people who are 30, 40 years old with no comorbidities were having strokes, and organs were failing as a result of these blood clots. And so a key element of the NHLBI response was driving the understanding of that coagulopathy and developing a strategy that looked at the entire course of the disease, those who are relatively mildly symptomatic, ambulatory, pre-hospital, as well as an in-hospital situation, as well as post-discharge, where that coagulopathy and propensity for blood clots persists, and figuring out who's most likely to develop those clots and what should we do to intervene to prevent their complications. And so literally in the last 2 months, we've launched what's called Active 4. It's really 3 master protocols: pre-hospital, in-hospital, post-hospital convalescence. They're testing different strategies to prevent this blood clotting. So that's a critical part of our strategy. Similarly, we recognized that there were blood-derived products that could be helpful in fighting this virus. It was known that obviously there are a number of people who are exposed to the virus and never develop symptoms, in part believe related to a very good immune response that then is able to mount so people don't really get sick. And clearly there are people who recovered. And so our blood division for years has strong programs in transfusion medicine and developed a strategy of using convalescent plasma, the plasma from patients who were successfully recovered from COVID-19 and whose bodies were clearly creating antibodies and other systems designed it very good at protecting, and whether using their convalescent plasma in a naive patient who had not yet mounted a response, whether that could be helpful. And obviously convalescent plasma has been around for over a century, but oddly enough, it had never been actually tested in a randomized controlled trial of any sort of robustness, more than dozens of people. And so literally we are now conducting one of the very few randomized controlled trials testing convalescent plasma in a context where it really hadn't been assessed, and that's in the outpatient basis. So people who are mildly symptomatic but at high risk for developing severe COVID, and to see if we can help boost their immune system by giving them convalescent plasma, passive immunity, such that we could prevent those kind of complications. So that trial, C3PO, has also been launched in the outpatient basis over the last couple of months. Now, in the meantime, we have actually finished a trial. So that initial trial of hydroxychloroquine that was begun in April, again, this platform works so effectively, particularly the investigators in the PEDAL network, that they rapidly accumulated over nearly 500 participants and provided us with enough information that we stopped the trial early, sort of late in June or so, and provided some of the first definitive evidence that put the controversies to rest, that indeed there really is no efficacy of hydroxychloroquine. We did not see a major safety signal, but clearly it was not effective. And that's why we stopped the trial, and that those papers are under review in a major journal. So clearly that was an important rapid response to make, because doctors were so unclear about what works, what doesn't. You were hearing a lot in the media. It's very confusing. A lot of retrospective studies were giving conflicting results. The way to answer it was with a randomized controlled trial, and that's what we did. And I think we put that drug to rest as an effective or useful approach. I probably could go on too long here, but those were amongst the things that the Institute has done in responding. Those trials that I've mentioned are all underway. We've also played a leadership role in understanding the complications of COVID in children. Some of you know there's a rare syndrome where it attacks the blood vessels of the heart and causes little aneurysms or outpouching and devastating complications of the heart in children, called the multi-system inflammatory syndrome in children, MIS-C. And so we're partnering with Child Health and AID to address that in children. And then I'll just finally wrap up by saying that we're also at the forefront of a trans-NIH effort to address COVID health disparities. We call it the SEAL program, Community Engaged Alliance Against COVID-19 Disparities, in which we recognize that it's important to engage the communities that are most adversely affected by this pandemic, and to ensure that they are included and are participating in this research, such that they can indeed reap the benefits. And so that involves an outreach effort to first raise awareness, address misinformation, myth busting, and address mistrust by engaging the community partners that are trusted by these communities to indeed enable them to adopt approaches, both preventative things like masks, social distancing, etc., that can help reduce those health disparities, as well as include them in the clinical trials and vaccine trials that are underway that we hope will ultimately benefit those same communities. So I'll stop there with those three major initiatives. I'm sorry, I went on a bit long there.
No, I'm glad you did, Dr. Gibbons. This is Erica Sword from the American Lung Association, and we're very appreciative of your time today. The questions are rolling in, so I'm going to jump right in if that's okay with you.
Sure.
Our first question comes from Nuala Moore at the American Thoracic Society. And she said, as you well know, the COVID-19 pandemic has heavily negatively impacted biomedical research across the country. Can you update us briefly on steps the Institute is taking to support the resumption of research studies, as well as opportunities to assist early career scientists?
Yeah, no, it's a very important question. We recognize, again, every corner of our society has been devastated by this pandemic. Clearly, we recognize that many of the health systems, particularly in the early days, and unfortunately, as it's moved around the country, have almost been overwhelmed by the impact it's had on health systems, straining health systems. And we recognize that many of our investigators have also been drawn into the fight, as it's been all hands on deck in hospital systems as well. We also recognize that it's been challenging to the degree to which COVID has been so dominant that ordinary procedures that ordinarily maintain a revenue stream for these health systems has had to be shut down as well. So We recognize that there's strains both financially and clearly the research laboratories in lockdown situations. The question raises a critical point, and that is we always are most concerned about those who are most vulnerable, and particularly our early stage investigators, our trainees. We recognize that we're going to have to make some adjustments as a community, as a collective. Now, I must say, we're still working with the appropriation that we had. So the FY20 budget did not contemplate this pandemic. And so, as you can imagine, it's challenging for us to say, well, can everybody kind of have a do-over of an extra year of money? Unfortunately, we weren't appropriated that. So at this point, it's really challenging to say, can we make everybody whole by restoring a year's worth of money? We only hit 3.5 billion to cover everybody. We'd obviously need another 3.5 billion to make everybody whole. So that request, quite frankly, is before Congress. We're nonpartisan, non-political, so but everybody here watches the news. We're not sure that there would be a supplemental that might address that. I know there's certain constituencies that are asking for that certainly that'd be helpful. But as we await that, I think what we are trying to do is see what we can do, particularly for those most vulnerable. And so we are looking at particularly the potential to provide supplements, perhaps for those trainees on the Fs and K awards as one option. Again, I can't make a commitment, but certainly if funds become available, those would be amongst our highest priorities.
You've said so many things right now, and I am trying to prioritize which follow-up I want to do with that. But I think I'm going to go to your talk a little bit about the disparate impact this disease has had. And you mentioned that cases of COVID-19 among American Indians, Alaska Natives, African Americans, Latinos is more than 2 times the rate of white Americans, and the deaths among African Americans especially are double the rate of whites. While socioeconomic status and occupation is impacting exposure, what can you say about NHLBI's research and investigation into this disease and why it's attacking people of color at such high rates?
Yeah, no, it's a great question, Erica. This pandemic, this virus doesn't discriminate, but it clearly addresses those who are exposed. And as you're pointing out, some of those groups occupy positions in our society where they are in essential services, where they are the front lines, maybe not always as doctors and nurses, but as the healthcare workers who move patients around the hospital, or as bus drivers, or grocery store clerks, places where they're exposed to the public and where this virus may be and circulate. They also often occupy positions where they may not have the option of taking sick leave, or where it's a major financial burden if they do. And so maybe they're in contexts where people come to work who may be spreading the virus. Similarly, they may be in a social situation where they can't work remotely because they're in a meat packing facility and they have to show up. And not like some of us on this call where we can work remotely. So when you don't have those sort of options, that can predispose you to that exposure. And then when you add on top of that, what we've learned about the virus, in which predisposing factors like obesity, diabetes, high blood pressure, coronary disease, asthma, all those things may predispose to severe COVID, and almost all those things we know have racial ethnic disparities. And so it really just, this virus just magnifies and reifies and just underscores the health inequities that pre-existed the pandemic in the midst of it. And it really shines a light on the importance of a research agenda that's targeting health disparities. And certainly the Institute literally was just launching a program called Decipher that was designed to address that actually had health disparity interventions, implementation science, taking what we know works and applying it in these communities in a community engaged way to address childhood asthma, hypertension control, a number of these factors that these communities struggle with. So it's been a high part of our agenda priority. I know for a number of the groups on this call, it's been a high priority, and this virus just reinforces why it needs to be, including after we conquer this. I'm optimistic we will. Not there yet, but we will. And when we do, we're still going to have to address those health inequities.
Absolutely. Thank you for that dose of optimism too, throughout all of this. Let me ask the next question from Sanjoy Dutta from JRGF. Is there any work on sex-specific differences that men are affected more than women in terms of how this disease is occurring?
There's some trends in some of the data, but almost as I was alluding to with the racial and socioeconomic disparities, you then have to tease apart the different exposure situations, potentially comorbid conditions. So you want to control for a lot of those factors. At this point, I don't think there's a great signal for that I'm aware of. But that is something we continually have to be vigilant for as to controlling all these other factors in which there are sex differences, whether there's an additional element. So that's where we need even more study.
Absolutely. Well, let's go back to the issue of funding, because as we all know that this kind of research obviously takes a significant investment. How has the Institute been using the emergency funding it received earlier in the year, especially recognizing that since that time, so much of our understanding of COVID-19 has changed? If NHLBI were to receive additional supplemental funding, what research would be prioritized in light of this?
Again, another terrific question. So as you point out, as part of the CARES Act, we received about $103 million of funding, and well, getting technical, it had a multi-year capability of spanning 4 years. And so we, as always, prioritize investigator-initiated science primarily. And as I kind of alluded to, we solicited ideas from the community, again, including those members on this call. And quite frankly, it was an overwhelming response. The community, again, I think wanted to rise to the occasion. So quite frankly, if we had funded everything that came in, it would have been well over $250 million. That's the magnitude of what is already come in the door. So we had to turn away a lot of science, and that we actually start to reduce and pull back, actually close down some of the notices of interest, because literally there was such a response that it overwhelmed that supplement. We also wanted to have a broad strategy, meaning we wanted basic sort of preclinical science, that there's still so much we don't understand about how this novel coronavirus is affecting the body, particularly heart, lung, blood, sleep systems. And we need to understand that at the most fundamental basic science level, in animal models, and in clinical research, and in population science. So that's one. Similarly, it was really important given the devastating hospitalizations and mortality, that we try some interventions, and that means clinical trials. And those, as you know, are very expensive. And so to launch some of these studies, and you might notice from the timeline, we were already committed to launching the ORCID trial with hydroxychloroquine actually before the money for CARES arrived. So we were committed to doing those sort of interventions, and those are expensive. Similarly, we think that there's an opportunity to learn more about this virus by developing what we're calling case registries, where we capture the spectrum of individuals who are mildly symptomatic, or in the hospital or convalescing, and developing strategies to systematically collect biospecimens, do analyses of imaging, and so forth, and actually create a cloud-based repository of all this data so that the investigator community can study that collectively, and again, dissect and understand how does this coronavirus affect heart, lung, and blood sleep systems. And we're leveraging our Biodata Catalyst platform that has all our top med and cohort data in it already, as really that discovery sandbox, if you will, to again stimulate research in this space. And furthermore, we're leveraging our legacy community-based cohorts, Framingham, Jackson Heart Study, Cardia, et cetera, because we think that there's an opportunity there that many of those individuals have probably been exposed to SARS-CoV-2. And because we had pre-COVID data, sometimes well over a decade, and then have the opportunity to continue to follow them post-COVID exposure for another decade, it may be the most unique opportunity to understand how this virus affects the trajectory, who's susceptible, why are some people asymptomatic and resilient to the infection, why do some people have a severe course. By leveraging those assets, we think our community will be able to ask and answer those questions. That's where we're investing the funds.
Wonderful, thank you. We're a little over time, but can you hang on for a couple more minutes, or do you need to go?
As you can see, this is energizing me. I probably should be shutting up more listening to questions. Oh yeah, I can give you a few more minutes there.
That's wonderful, I appreciate that. This question is from John Loeffner from the American Heart Association. You mentioned that convalescent plasma may be an effective treatment for COVID-19. If proven effective, how easy would it be to produce or reproduce plasma donated from patients? How much could come from one patient, for example? Would we be able to produce that at a larger scale?
Yeah, again, another very good question. I think these are some of the things that we hope the study will start to explore. As you know, there have been some explorations that were primarily based on compassionate use, and a registry was created that probably established that it's safe, but because it was not a randomized control trial, it really couldn't address how effective it could be. And so there are a lot of things that we still don't know. So for example, if the three of us on this panel, Erin, Erica, and myself, all had COVID, and each of us donated plasma, the amount of, let's say, neutralizing antibodies that are great at blocking the virus's effect inside may be different. And so understanding that variation, even from lot to lot, in terms of our responses, could be important. But how severe the COVID was, how does that affect what is in the convalescent plasma? What is the right, again, dose amount to give? Those are questions that still need to be sort of established and are best established in a randomized controlled trial, where I think we still have clinical equipoise prior to hospitalization as to whether they can advance things. Similarly, I can say also that there are efforts made to extract the immunoglobulin. So hyperimmune immunoglobulin derived from the blood is also being tested in a protocol within the active portfolio. And then, as you all know, with recombinant technology, it's possible to go in and take some of those recovered patients and actually clone out the neutralizing antibodies that you think work, and those are being tested I won't mention it, but yeah, there was a very famous patient in a clinical trial that many of us heard in the news that received one of those agents being experimentally tested at this time in terms of monoclonal antibodies. Actually, our networks are also doing those in outpatients and inpatients as well. So that's another promising therapy that indirectly is another blood-derived kind of approach of passive immunity.
Wonderful. Okay. That's very fascinating. How has the pandemic influenced the strategic priorities of NHLBI? Looking ahead towards next year, and understanding that we are in a CR, which always makes much more difficult for planning, what do you think the biggest issue that needs to be addressed is, and what additional resources are needed to accomplish this?
Wow. As you say, there's a lot of uncertainty. You started off with your first question about, one of the risks is the vulnerability of our currently supported investigators as they try to just survive this pandemic. So that certainly is one issue. And as I tried to indicate, our priorities are often on those who are most vulnerable, who have the least resilience to this kind of effect, and sort of starting with the next generation. So that was a priority before, has always been in terms of our K awards, our established investigator success rates in the 20s, et cetera. We're going to need to, even in a CR, see what we can do to maintain that. And as I mentioned, funds are available, supplement some of those Fs and Ks to kind of tide them over. We recognize it's going to be a tough job market for some of those trainees who want to make a transition to independence. So again, we want to be sensitive to that. Similarly, although we've been talking COVID, all my staff are continuing their day job. They're still supporting all the R01s and the PPGs, et cetera. And so that business of our base still goes on, and we're committed again to maintaining that the best way we can with investigator-initiated discovery science. And across the spectrum of basic, translational, clinical, population science. We are still pursuing the Cure Sickle Cell Initiative, and actually are encouraged that there's some promising things in the pipeline for phase 1, moving into patients actually with curative therapies. I'm very excited about that. We want to push that forward. This is no time to let off the gas pedal on some of those movements. I mentioned what we're doing in precision medicine and top med, which continues to move with over 150,000 whole genomes in a cloud-based platform, Biodata Catalyst, that continues to move forward. So we have a number of initiatives we're very excited about that we hope to maintain. Obviously, it's always harder with a flat budget because unfortunately, those R01s cost more every year. And so even a flat budget is actually taking some things off the table. So we hope we can get an appropriation that continues the trend over the last 4 to 5 years that is recognized that we just are getting back to where we were before that decade of stagnation. And we have so much momentum of exciting things we need to do that we need to keep pressing on and making those investments. Thanks.
Wonderful. I'm going to sneak in 2 more questions if it's okay with you, Dr. Gibbons. The next one comes from Richard Turman from Act for NIH. What lessons learned about how quickly NHLBI has been able to move during this pandemic could be applied in the future once we're past the pandemic and be applicable to other diseases in NHLBI's portfolio?
Well, it's a very interesting question. I think someone said, never let a good crisis go to waste. As devastating as this pandemic has been, it's taught us a lot. And how innovative, resilient, resourceful people can be, even in the most dire situation. And so first, I'm thankful for the public servants that I'm so proud and privileged to serve alongside. It's been incredible for them to keep their day job, keep the trains moving on all the other programs, and then double down and also be moving COVID programs through at warp speed as the government moves. I mean, to go to launch a protocol by April that just came in March, that says something. And again, it's with still due diligent care of peer review and IRB and DSMB, but it does suggest that with that focused attention and that goal, we probably can be a little bit more nimble and accelerate to velocities to meet the challenge. And so I think that probably will be a lesson learned for all of us. A lot of lessons learned, including, I guess, doing briefings by Zoom. And whether that is as good as in person. So yeah, no, a lot of lessons learned in this.
Absolutely. Well, Dr. Gibbons, my final question to you before we thank you for your time is, what can our advocacy community do to help you and NHLBI during this time?
Well, first, let me express my appreciation for the circle of partners that are gathered here. We need everyone. This is a moment in our country where we have to do this together as a collective, as an ecosystem. It's been extraordinary, actually, the public-private partnerships. The private sector has been working very collectively. And so it's really both humbling and inspiring how the various elements of this country can come together in a moment of crisis and work together to try to do something. And I see, again, some effectiveness of that intervention. I'm very, as I alluded to, very pragmatically optimistic. I think probably the nature of a clinician scientist. I think science will beat this virus. And it will save lives. The NHLBI community, I think, will be a critical driver to that. It already has been, and we need your support to continue to be so. I believe our community is at the vanguard of making a difference and conquering this virus at multiple levels. And yes, it takes resources to do that and continue the priorities that we've begun. So we appreciate everything you do to support the work that we do through you in collaborative partnership. So thank you for your ongoing advocacy and support.
Well, Dr. Gibbons, thank you for your amazing leadership and really your incredible ability to balance both this pandemic and making sure, as you said, that the other work is continuing to move forward at the same time. So on behalf of the American Lung Association, I want to say thank you, especially for joining us today. And now I'm going to turn it back over to Erin.
Thanks, Erica, and I will echo Erica's thanks, Dr. Gibbons. This was a really great discussion. And so thank you, Erica and Mary Lee, for excellent hosting today. And on behalf of the Coalition for Health Funding and the Ad Hoc Group for Medical Research, thank you all for joining us today. And this concludes our webinar.
All right, thank you.